Hello students, before we begin our lecture, I would like you to concentrate on this picture and identify it. Yes, it's a picture showing different poses of Surya Namaskar. But as a medical student, I would ask you to identify the different movements which are taking place at different joints. Yes, today we'll be concentrating on one particular joint, that is the knee joint. In the Surya Namaskar position, you can see that the knee joint is undergoing various different ranges of movements of flexion and extension. Now you will think that it's only the flexion extension that is taking place at the knee joint. But if I tell you that these flexion and extensions are associated with conjunct rotations, yes, to understand them better, we should know the knee anatomy first. So today's lecture is on knee joint. We'll be learning the knee joint under the following headings: the type of joint, its articular surfaces, the capsules and the ligaments surrounding the knee joint, synovial membrane and bursae around the knee joint, and the relations of the knee joint in today's lecture. The subsequent portions of the knee joint, like movements and applied anatomy, will be done in the second part of the knee joint lecture. Knee joint is the largest synovial joint in the body. It is a compound synovial type of a joint. It's also called as complex joint because of the complex arrangement of extracapsular and intracapsular ligaments surrounding the knee joint, which helps to counter the biomechanical damages on the joint because it is always constantly under severe stresses. It carries severe stresses with wide range of movements. The knee joint is formed by the articulation between multiple bones. Those bones are the lower end of the femur, the upper end of the tibia, and the posterior surface of patella. Please note that the fibula is not contributing to the knee joint. So, this knee joint, although it appears as a single joint cavity, but it is divided into three distinct and partially separable compartments. So those compartments are between the individual the lateral and the medial condyles of the femur and the tibia, and between the femur and patella. The type of joint which is between the lower end of the femur, that is between the condyles of the femur and the condyles of the tibia, is the tibiofemoral joint, which is condylar variety of synovial joint. The other joint which is between the patella and the femoral condyle, anterior surface of the femoral condyle, this is the patellofemoral joint, and it is a saddle variety of synovial joint. The articular surfaces of the knee joint are the femoral articular surface on the anterior and the inferior surface of the lower end of femur, the tibial articular surface which is on the superior surface of tibial condyles, the patellar articular surface which is on the posterior surface of patella. Now looking into the articular surfaces, we can clearly see that the convex femoral condyle is articulating on the concavity of the tibial condyles, which is not that deeper. So we can make out that the articular surfaces are incongruent surfaces. The stability of a joint depends mainly on the structural fitting of the articular surfaces. Although the articular surfaces are incongruent, there are other factors which will increase the congruency of this joint, which we'll learn in the further slides. Now these are the pictures of femoral condyles from different profiles: anterior, posterior, lateral, and the medial profiles. What we can see clearly over here is that the shape of the condyles, femoral condyles, both medial and the lateral femoral condyle, is convex. The convexity is not only in the anterior posterior plane, but it is convex from side to side as well. In the lateral and the medial profile, we could see in the sagittal profiles, we can see that it is curved. The femoral condyles which are curved, the curvature begins from this anterior aspect and then it is accentuated and increased posteriorly. Now, on comparing the medial femoral condyle with the lateral femoral condyle, we can clearly see that the shape of a medial femoral condyle is that of an oval shape. This lateral femoral condyle is more of a rounded circular. The anterior-posterior extent of a lateral femoral condyle is smaller as compared to a larger anterior-posterior extent of medial femoral condyle. The curvature in both medial and the lateral femoral condyle is flatter in the anterior part and more curved in the posterior part. Here also it is flatter in the anterior part, more curved in the posterior part. But we can see clearly that in the lateral femoral condyle, the curvature is flattening rapidly, making it a single arc. Whereas in the medial femoral condyle, the curvature flattens gradually. A double arc is formed in the medial femoral condyle. The anatomy of knee joint is corresponding with its physiology. So unless we know the anatomy of the femoral condyle, we will not be able to understand the role in its movements. So as we had seen that the femoral condyles, both the lateral and the medial ones, were flatter on the anterior part, and they were more curved on the posterior part. So what happens during full extension position? During full extension position, the articular surface, the inferior articular surface of the femoral condyle, the anterior part of it, which is more flatter, articulates with the tibia in the extension part. When the knee joint is in full flexion position, the more posterior part of the articular surfaces of the femoral condyles, which is more curved part, articulates with the tibia. So we are done with the femoral articular surfaces. Now coming to the tibial articular surface. The tibial articular surface on the lateral condyle and the medial condyle of the tibia are covered by articular cartilages, same as that of the femoral condyles were covered by articular cartilages. They are hollow centrally, concavity here, and flattened peripherally. The upper end of the tibia is separated by the intercondylar area, which is non-articular area. So in this picture, we can see, in the second picture, we can see the green area is all the area which is involved in the tibial articulation. Now, the tibial concavity is not that deep, as we mentioned earlier, making it an incongruent articular surface. So this tibiofemoral congruency is increased by the presence of menisci. The menisci, which fits into the superior surface of both tibial condyles, is going to increase the congruence. Like both the lateral and the medial femoral condyles were different in their shapes and structural composition, similarly, the tibial articular surface on the lateral side and the medial side are different. We can see that the anterior-posterior extent of the medial tibial articular surface is more, same as that of the medial femoral condyle, whereas the lateral one is smaller. The shape also corresponds well with the femoral condyle on the medial side. The medial tibial articular surface is oval in shape, same as that of the medial femoral condyle. The lateral femoral condyle was circular. Similarly, the tibial articular surface on the lateral tibial condyle is also circular. Now, in this picture, we can see a relation of tendon of popliteus. The articular margin of the tibia on the lateral side is related to the tendon of popliteus. This is an important relation which will help us in the next slide. Now the last articular surface is the articular surface of patella, which is actually the posterior surface of patella. The posterior surface of patella is divided by a vertical ridge into a lateral facet and a medial facet. By further vertical ridge, it is divided into a very small facet which is called as odd facet at the medialmost end. Then the two horizontal line divides the vertical facet and the medial facets into further 6 compartments. So the superior one on the medial side is called as a superior medial facet. This is a superior lateral facet. This is the medial middle facet. This is the middle lateral facet. This is the inferior medial facet, the inferior lateral facet. So these particular facets are going to articulate with the patellar surface of the femur. During full extension, the lowest facets are articulating. The odd facet articulates in the full flexion position. So after understanding all the articular surfaces involved in the knee joint, we came to a conclusion that the articular surfaces were incongruent surfaces. To improve the tibiofemoral congruency, we mentioned that meniscus are required. Meniscus are the C-shaped fibrocartilage plates which are there on the articular surface of tibial condyles. Their main purpose is to deepen the articular surface of the tibial condyles so that it increases the congruency of the joint, providing the stability and even spread of load to the joint. The underlying bones are also cushioned by these menisci. And assistance in the lubrication is another function of meniscus along with proprioception. Now, meniscus, this is a picture showing you the lateral meniscus, and this is the medial meniscus. It's a transverse section, anterior, posterior, lateral, and the medial side. So, the meniscus on the lateral side and the meniscus on the medial side. We can clearly see its parts. These are the horns of the lateral meniscus, anterior horn. This is the posterior horn of the lateral meniscus, which is the fibrous ends of the menisci, through which they are attached to the intercondylar areas. On the medial meniscus, this is the anterior horn of the medial meniscus, and this is the posterior horn of the medial meniscus. The borders are two. The inner border is thinner, the peripheral border is thicker and fixed, attached to the margins of tibial condyle by peripheral fusion with the capsule. Now, the surfaces are the superior surface and inferior surface. The surface that we are seeing right now is the superior surface, which articulates with the femur, femoral condyles. The inferior surface is articulating with the tibia. Now, what is the attachment of the meniscus? As I've told you, they are attached to the intercondylar area through their horns. Now, as we go from anterior to the posterior part of the intercondylar area, we can see some relations which are very important for you. So these are the relations at intercondylar area from anterior to posterior. The first impression over here on the anterior intercondylar area on the medial side is that of the anterior horn of medial meniscus, which is over here, anterior horn of medial meniscus. Just behind that, there is a attachment of certain ligaments. I'll come to that later. So on behind this anterior horn of medial meniscus is anterior horn of lateral meniscus. Between the two, there is an attachment of ligament, which is the anterior cruciate ligament. Then as we go posteriorly, there is attachment of posterior horn of lateral meniscus, followed by posterior horn of medial meniscus. And then there is one more ligamentous attachment, posterior most, which is the posterior cruciate ligament. So by this first picture, what we can understand is that the attachment of meniscus is attached to the intercondylar area by their horns, while the margins of tibial condyle, they are attached to the margins of tibial condyle by peripheral fusion with the capsule. So that is how the peripheral border of the meniscus are fixed and attached. The inner margin is now free. The attachment, to remember these attachment, you just simply see this picture and remember that similar to the medial femoral condyle, medial tibial condyle, they were longer anteroposteriorly as compared to the lateral one on both femur and tibia. So the meniscus will on the medial side would also be longer anteroposteriorly. So the longer medial meniscus, the horns should be farther apart. So the first impression of attachment over here in the intercondylar area should be that of anterior horn of medial meniscus, and the last attachment on the on the intercondylar area for the meniscus should be for the posterior horn of medial meniscus. Because the lateral meniscus is smaller in anteroposterior extent, both its anterior and posterior horns will be closer, right? So now let's summarize all the relations at the intercondylar area from anterior to posterior, which is important for you. So the first is, yes, it is anterior horn of medial meniscus. The second is anterior cruciate ligament. Third is anterior horn of lateral meniscus, followed by posterior horn of lateral meniscus, then posterior horn of medial meniscus, and the last one is posterior cruciate ligament. So how to remember it? As I've told you, for the attachment and the relation of the anterior of the intercondylar area, just remember always the medial meniscus will be longer, same as the longer length of anteroposterior extent of femoral condyle and tibial condyle. Similarly, the medial meniscus will be longer, so their horns will be farther. Since the lateral meniscus is smaller, their horns will be closer to each other. So the horn anterior and both the anterior and posterior horn of medial meniscus will be farther apart. The lateral meniscus anterior and posterior horns will be closer apart. For remembering the attachment of the cruciate ligament, remember anterior one is between the two anterior horns and the posterior one is the most posterior most. So remember this order of attachment on the intercondylar area from anterior to posterior in order. So now coming back to the menisci, the blood supply of the meniscus peripheral part is from the capillaries, from the capsule and the synovial membrane, whereas the inner part of the meniscus is avascular. So the medial meniscus is semicircular shape. Lateral one is more circular, similar to the circular rounded shape of the femoral condyles on the lateral side and the tibial condyles on the lateral side. Anteroposterior extent also narrower in the lateral side. The breadth is uniform in the lateral meniscus, while the medial meniscus is broader posteriorly. There is an important relation of the medial meniscus that the peripheral margin is attached to the tibial collateral ligament, because of which it becomes less free to move on tibia, and hence the tears, meniscal tears, are more common onto the medial side. Whereas the lateral meniscus is free to move on tibia, the lateral meniscus has a relation with the popliteus tendon. It is related posterolaterally by the tendon of popliteus. The anterior horn of medial meniscus is connected to the anterior margin of lateral meniscus through transverse ligament. The posterior horn of lateral meniscus is attached to the medial femoral condyle through meniscofemoral ligament. It has two components: anterior meniscofemoral ligament, which passes in front of the posterior cruciate ligament, and the posterior meniscofemoral ligament, which passes posterior to the posterior cruciate ligament. The mobility of meniscus is controlled by the surrounding structures around the menisci. The medial meniscus is attached to the tibial collateral ligament. Because of this attachment, the medial meniscus becomes less mobile on the tibia. Whereas by the pull of the popliteus and by the relation of meniscofemoral ligament, the lateral meniscus is moved with the action of popliteus. This makes the lateral meniscus more mobile on the tibia and hence less susceptible for the meniscal tear. The meniscal tear and all the applied aspects we'll learn in the later subsequent. So now coming to the capsule of the knee joint. The capsule of knee joint surrounds the knee joint. It is attached along the articular margins of the articular surfaces. So we know what are the articular surfaces already. This is the femoral articular surface on the anterior and the posterior part. The tibial articular surfaces, showing the tibial attachment of the capsule on the anterior and the posterior part. So with the dotted lines in these diagrams is the attachment of capsule over here. The capsule is attached along the articular margins. See carefully, this is the articular margin on the anterior aspect, so it is all along the articular margin. In the posterior part also, it is along the articular margin of the lower end of femur. In the tibia, it is along the articular margin, extending onto the tibial tuberosity, margins of the tibial tuberosity. And posteriorly also, on the tibia, it is along the articular margin. But on tracing the capsule, you can clearly see that the capsule is deficient at some places. So it is deficient anteriorly, both on the femoral aspect and on the tibial aspect. So this deficiency, which is anteriorly, is replaced by the patellar tendon. There is one more gap in the or deficiency in the capsule, which is posterolaterally related, posterolaterally on the tibia. This is for the passage of tendon of popliteus. So the tendon of popliteus passes out from this gap through the capsule. But the origin of popliteus, which is on the lateral aspect of the femoral condyle, it is intracapsular. So this first picture is showing the anterior aspect of the knee joint. The second picture is of the posterior aspect of the knee joint. So we can see these fibers of capsule which is surrounding the knee joint, both anteriorly and posterior in the posterior part of the knee joint. We can see clearly that anteriorly this capsule is deficient and is replaced by the attached tendon of the quadriceps femoris and the ligamentum patella. The structures which strengthen the capsule are the surrounding structures, extensions from the surrounding structure. Laterally, it is strengthened by the iliotibial tract, the extension from the ligamentum patella and the extension from the vastus lateralis to the ligamentum patella, which is the lateral patellar retinaculum. The extension from the vastus medialis to the ligamentum patella, there is a medial patellar retinacula that is also going towards the capsule and strengthening it from the medial side. The semimembranosus tendon also sends some fibers posteriorly, which fuses with the capsule. This is called as the oblique popliteal ligament. This also strengthens the capsule along with expansions from the sartorius. And now students, this is the picture which is the transverse section from the right knee joint. This picture you should know how to draw, and before drawing you should know the relations of this particular diagram. So in this transverse section, this is the anterior part, the posterior part. Now you will tell me which one is the medial and the lateral portions of this section. Yes, by looking into the tibial condyles or the over which the medial and the lateral meniscus are located, by looking into the shape of the meniscus, can you make out which is the medial and the lateral one? Yes, this longer one is the medial meniscus. So this is the medial side and this one is the lateral side. So showing the narrower lateral meniscus. Also, for understanding the anterior and the posterior portions. Now look into here. This is the ligamentum patella in the front, and posteriorly you can see some muscles over here, which are the muscles of the back. Now this green structure is the capsule. So we just completed the capsular attachments and the extent of the capsule and the structure strengthening edge we have done. So the capsule, now let's trace the capsule from front to behind. So this was the capsule, and we can clearly see that the capsule is absent anteriorly and is replaced by what? What is the structure? Yes, this is ligamentum patella. And so the capsule is deficient anteriorly, and then from the margins of the ligamentum patella, these are the medial and the lateral patellar retinacula, which strengthen the capsule. Now the capsule is all along the articular margin. You can see this is the articular margin of the lateral tibial condylar area. So this is the capsule on the lateral side of the tibial condyle along the articular margin. Now see an important relation over here. Now this green structure over here is the tendon of popliteus. So you can see that the tendon of popliteus is intracapsular, but there will be a gap of it in the capsule. From there the popliteus tendon will be passing out of that gap. Now this tendon of popliteus, we also said that is related to the posterolateral aspect of the lateral meniscus. Now further tracing the capsule posteriorly, this is the capsule which is covering the posterior articular margins of the tibia. Now in front of it there's a posterior cruciate ligament. So we can see that the cruciate ligament, both posterior and the anterior ones, are also intracapsular, that is they are within the capsule. Now this is the tendon of semimembranosus. This is tending of expansions from towards the direction of the capsule. So this is the oblique popliteal ligament, another structure which strengthens the capsule. Now further tracing onto the medial side, this is again all along the articular margin. Now here comes another structure. This is the medial collateral ligament. This medial collateral ligament is fused with the capsule and is also fused with the margins of the medial meniscus that we have already discussed. And this was the reason why medial meniscal tear were more common, due to its fixity to the medial collateral ligament. So now further tracing the capsule on the anterior aspect, now we can see it is merging with the medial patellar retinacula, which is extension from the vastus medialis. So this is ligamentum patella. This is the lateral meniscus, the medial meniscus, capsule, its relation with the tendon of popliteus, its relation with the medial collateral ligament. After capsule, we now come to the synovial membrane. Like any other synovial joint, in the knee joint also, the synovial membrane is going to line the capsule. But here it is more extensive and complex. Now look into this picture. This dotted line, black dotted line, is representing the synovial membrane. We can see clearly that the synovial membrane is lining the capsule everywhere, except at one place. This is the posterior part of the capsule, where the synovial membrane is not lining the posterior part of the capsule, but got reflected in the forward direction or anterior direction and enclosed both the posterior cruciate ligament and the anterior cruciate ligament. So apart from lining the capsule, the synovial membrane also lines few structures which are within the capsule. Now, this first structure is the infrapatellar pad of fat. This intrapatellar pad of fat is lying behind the ligamentum patella. The other structure is the tendon of popliteus. This tendon of popliteus is intracapsular. But look into the relation of synovial membrane with the tendon of popliteus. It is covering the tendon of popliteus as well as lining the intrapatellar pad of fat. So now we have understood that the synovial membrane is quite complex and extensive. Now let's see its complexity and extensivity in more details. So the synovial membrane is not as simply lining the capsule as elsewhere in other joints. In knee joint particularly, the synovial membrane is reflecting. So we'll see all the reflections of synovial membrane. One of the reflections we already talked about was when it was reflecting from the posterior part of the capsule, reflecting in the anterior direction to enclose the cruciate ligament. So this is that fold of reflection in the second picture. Now, we also talked about the intrapatellar pad of fat and how the synovial membrane was lining it or covering it. This intrapatellar pad of fat was present behind the ligamentum patella. So this synovial membrane, which gets reflected in a backward direction from the posterior surface of ligamentum patella, having the intrapatellar pad of fat, covering the intrapatellar pad of fat, is called as, this fold is called as infrapatellar fold. This is infrapatellar fold. In the second picture also we can see the infrapatellar fold. Now the margins of these folds are called as the alar folds. So these are the free borders of the infrapatellar fold known as alar folds. So in this picture, when the knee joint has been opened up, we can see the alar folds and the infrapatellar fold. Now the one more fold, which is in relation to the popliteus tendon, this is the subpopliteal recess. So these are the reflections of synovial membrane. Now, few more extensions of the synovial membrane, which may or may not communicate with the joint cavity, are the bursae. They are present at the sites where the skin, muscle, or tendon rubs against the bone. They are divided into anterior bursae. The anterior bursae are the suprapatellar, prepatellar, superficial intrapatellar, and deep intrapatellar bursa, the name according to their positions. The suprapatellar bursa is between the lower end of femur and the quadriceps muscle. Prepatellar bursa is a subcutaneous bursa which is between the skin and the lower half of the tail. Another subcutaneous bursa is the superficial intrapatellar bursa, which is between the skin and the distal part of the tibial tuberosity. The deep intrapatellar bursa, this is the deep intrapatellar bursa, which is between the tibia and the ligamentum patella. Posterior bursae are the popliteal bursa, which is related to the tendon of popliteus, and with the insertion of semimembranosus muscle is the semimembranosus bursa. The other bursae which are related are with the relations to the tendon of biceps femoris, sartorius, gracilis, and semitendinosus. So now we come to the ligaments surrounding the knee joint. The ligaments which surrounds the knee joint are divided into two categories, the extracapsular ligaments and the intracapsular ligaments. We have already seen how anterior and posterior cruciate ligament were lined by the capsule. So these two are the intracapsular ligament. Now, the rest of the ligaments are extracapsular. That means they are not lined by the capsule. They are present outside the capsule. Those are ligamentum patellae, medial collateral ligament or the tibial collateral ligament, fibular or the lateral collateral ligament, and oblique popliteal ligament. Ligamentum patella is the continuation of quadriceps femoris tendon. It is attached above to the apex and the lower parts of the deep surface of patella, and below it is attached to the tibial tuberosity. It stabilizes the patellofemoral joint. In this picture also, we have already seen this was the ligamentum patella. And medially and laterally, the expansions from the medial side is the expansion of vastus medialis, and from the lateral side is the expansion from the vastus lateralis, which blends with the capsule, strengthens it, and are known as these expansions are known as the medial patellar retinaculum and the lateral patellar retinaculum. Now coming to the collateral ligaments. On the lateral side is the lateral collateral ligament or the fibular collateral ligament. It is a very strong cord-like ligament. This is attached above to the lateral epicondyle of the femur, and below it is attached to the head of the fibula. Its important relation is with the popliteus tendon. This is the popliteus muscle, and this is the tendon of popliteus. The tendon of the popliteus is between the fibular collateral ligament on the lateral side and the lateral meniscus. The fibular collateral ligament stabilizes the lateral side of the knee joint and will prevent medial flexion of the knee joint. So it is going to strengthen the knee joint from the lateral side. On the medial side, there is medial collateral ligament or the tibial collateral ligament. Unlike fibular collateral ligament, this is not cord-like, but this is broader ligament. It is flattened and broadened ligament. It is attached above to the medial condyle of femur. As it goes down, it splits into two layers. This is the deep layer, which is attached to the articular margin of medial tibial condyle, and this is the superficial layer, which is attached to the medial surface of the shaft of tibia. The important relation of the medial collateral or the tibial collateral ligament, which we had already discussed, was this is the medial meniscus. We said earlier that the medial meniscus is attached to the tibial collateral ligament. So which part of the tibial collateral ligament the medial meniscus should be attached? Yes, it should be attached to the deep part of the tibial collateral ligament. And remember, this was the factor which made medial meniscus less freely movable on the tibia, making it more susceptible to medial meniscal tear. The posterior part of the tibial collateral ligament blends with the capsule. Like the fibular collateral ligament was strengthening the joint from the lateral side, the medial collateral ligament or the tibial collateral ligament will stabilize the knee joint from the medial side and will prevent the lateral flexion of the knee joint. Another extracapsular ligament which we already discussed was the expansion from the semimembranosus tendon into the posterior direction or along the posterior surface of the knee joint, and this was strengthening the capsule from behind. So this is extension from the semimembranosus tendinous expansion known as oblique popliteal ligament. It is going to strengthen the posterior aspect of the capsule. Now, there is one more extracapsular ligament, which is the arcuate. This is the arcuate popliteal ligament. It is a Y-shaped band of ligament, which is having a stem attached to the head of fibula. It has got a posterior limb which arches medially and reaches the crosses over the tendon of popliteus and then blends with the oblique popliteal ligament. The anterior limb reaches the lateral epicondyle of femur. So this is arcuate popliteal ligament, again an extracapsular ligament. So now we are done with the extracapsular ligaments, which were fibular collateral ligament, tibial collateral ligament, oblique popliteal ligament, arcuate popliteal ligament. So now we are left with only the two intracapsular ligaments, which are the cruciate ligament. Cruciate or the cruciform means letter X cross position. So here we can see clearly there are two ligaments, intracapsular ligaments within the joint cavity lined by the capsule. They are crossing each other in a letter X-like fashion. These are called as the cruciate ligament. These cruciate ligament are very strong ligament, and actually they are the only main bond between the femur and tibia throughout the various joint range of movements. Now they are of two types: anterior cruciate ligament and posterior cruciate ligament. When we were doing meniscus, we had already seen its relation: anterior cruciate ligament and relation of posterior cruciate ligament with respect to the meniscal horns. So the anterior and posterior name is in respect to its attachment on the tibia. So we had seen that the attachment of the anterior cruciate ligament on the tibia was anterior, and the attachment of posterior cruciate ligament on the tibia was more posterior. So because they are going in a crossing direction, so they are going to be attached more. The anterior cruciate ligament is going to be attached more posterior on the femur. But the name, it has got its name anterior cruciate because it is attached to the anterior part of the tibia. So the anterior, so do you remember this picture, students? Yes, this arrow is denoting the attachment of anterior cruciate ligament. So the anterior cruciate ligament originated from where? It originated from the intercondylar area between the horns of anterior horn of medial meniscus and anterior horn of lateral meniscus. So the name is anterior cruciate because the origin from the tibia is more anteriorly, as we already discussed. So because it is a cruciate ligament, it has to cross to the opposite side. So from when it is originating from the anterior portion of the tibia, where will it go? It will be attached to the posterior portions of the femoral condyle. Which femoral condyle? Lateral femoral condyle onto its medial surface. This is the lateral femoral condyle, and this is the medial surface of the lateral femoral condyle. So it will go attached to the posterior most parts of it. The main function is to prevent the posterior displacement of femur on tibia. So you can see one end is attached to the tibia, the other end is attached to the femur. So during the range of movement, flexion, extension, they are going to prevent the displacements of femur on the tibia, as well as prevents the displacement of tibia from the femur. So because it is attached onto the tibia anteriorly, so it is going to prevent the posterior displacement of femur. And when the knee is flexed, that means the tibia is free. It will prevent the tibia from being pulled anteriorly. So tibia can't move anteriorly because it is still held with the posterior portions of the femoral condyles. So we already discussed the relation of intercondylar area. Here, the posterior most impression was for the posterior cruciate ligament. The posterior cruciate ligament is more larger and stronger as compared to the anterior cruciate. It is attached to the posterior intercondylar area of the tibia. In relation also we saw this was a posterior most relation. So this is the origin point. Where will it insert? It will, again, because the posterior cruciate ligament also has to cross to the opposite side. So it is going to go to the medial femoral condyle. And it will attach where? On the anterior or posterior part? Yes, because it began from the posterior end, so it will insert to the anterior portions of the medial femoral condyle onto its lateral surface. Now, the functions of posterior cruciate ligament will be to prevent the anterior displacement of femur. So the femur will be protected from displacing anteriorly on the tibia. And when the knee joint is flexed, that means when the foot is off the ground, the tibia, it will prevent the tibia from being pulled posteriorly. So the function is exact opposite of the anterior cruciate ligament. So now coming back to this picture, of knee joint, transverse section of right knee joint, showing all its relations. So I'll explain once again. This was the anterior and the posterior aspect of this transverse section. And now you already know, even if there is no labeling, which is the lateral side. Yes, with the shape of the lateral meniscus, you can make out this is the lateral side and this is the medial meniscus. So this is the medial side. Now just revising all the structure together, this was the ligamentum patella, the cruciate posterior and the anterior cruciate ligaments. Now the relations, anterior relation. What should be the anterior relation of the knee joint? Yes, it is the quadriceps femoris tendon or ligamentum patella. The relation anteromedially would be the medial patellar reticula, which is the expansion of vastus medialis. Anterolateral relation would be the lateral patellar reticula, which is the expansion from the vastus lateralis. Posterolateral relation would be the biceps femoris and common peroneal nerve. Posterior medial relation would be the muscles over the posterior medial aspect. These are the sartorius and gracilis. The posterior relation would then be the popliteal vessels, popliteal artery and popliteal vein, and the tibial nerve, and the lymph nodes lying on the oblique popliteal ligament. These are the relations of the knee joint. Now at the end, let's do the summary of the lecture. Knee joint is the largest joint and is composed of compound synovial type of joint, with tibiofemoral joint as a condylar type and patellofemoral joint as the saddle variety. The articular surfaces of the knee joint is incongruent. The meniscus are fibrocartilaginous disc which deepens the tibiofemoral articular surfaces, increasing the congruency of the articular surfaces, and also partially divide the joint cavity into upper and lower compartments. Capsule surrounds the knee joint and is deficient anteriorly, where it is replaced by the quadriceps femoris tendon, patella, and ligamentum patella. There are ligaments surrounding the capsule which are important for strengthening the knee joint. They are extracapsular, like ligamentum patella, medial collateral ligament, lateral collateral ligament, oblique popliteal ligament, and there are two intracapsular ligament, anterior cruciate ligament and posterior cruciate ligament. Thank you. Now, at the end, I would just like to show you this picture, and you have to identify the structures attached to the marked area 1, 2, 3, 4, 5, and 6. Write it down somewhere and revise everything which has been taught today. Thank you. Hello students, before we begin,
Hello students, before we commence to our today's lecture, I would like to show you this picture. I'm sure everybody has noticed the similarity between the two pictures, both involving the same region that
is the age of both the individual. The first picture shows an older individual with a knee pathology, and the other picture, second picture, shows a younger athlete with a different conditions of the same knee joint. So, by keeping that picture in our mind, we now commence to our second part of knee joint. The first part, we already covered the anatomy of the knee joint. In the second part, we'll cover all the applied aspects related to the knee joint and the movement of the knee joint. The various applied aspects related to the knee joint are the meniscal tear, ligament injury involving the tibial collateral ligament, fibular collateral ligament, the two cruciate ligaments, anterior and the posterior cruciate ligament, knee arthroscopy, knee osteoarthritis, and knee replacement surgery. Now, to begin with the meniscal tear first. Before we begin the meniscal tear, let us first revise the anatomy of the meniscus. This picture is showing the superior surface of the tibia with menisci. This is the anterior portion showing the tibial tuberosity, and now we know because of its longer anterior posterior extent, this is the medial meniscus and the other one is the lateral meniscus. We can appreciate a tear over here. This is the meniscal tear. So, and this is on the medial side. So now let's see what is the mechanism of injury to the meniscal tear. Meniscal tear, can you see this picture, the first picture? This is showing an athlete. So look closely to his knee joint. The knee joint on the right side, you can appreciate that it is semi-flexed. It is semi-flexed and also weight bearing. That means the foot is touching the ground. So in meniscal tear, The position of the knee joint is semi-flexed, and the foot is touching the ground. It is taking the weight of the body. Now, the other person is giving the direction of impact to the knee joint of the diseased individual. So in this condition, what is happening is that, look carefully, that the femur on the affected side, that is the right side, is rotated on the tibia. So this rotation of femur is taking place on the tibia when the foot is still touching the ground. This meniscal tear can happen if foot is off the ground. In that case, the tibia is going to rotate on the femur. So with the first condition in our mind, that is foot on the ground, now what happens because of this direction of impact? The tibia will be abducted. This is a picture showing the tibia. The tibia will be abducted on the femur. This leads the medial meniscus to be pulled into an abnormal position between the femoral condyles and the tibial condyles. The sudden movement between the condyles, femoral and the tibial condyles, will result in the grinding forces on the menisci, and this leads to a longitudinal tear. This longitudinal tear is called as the bucket handle tear. So after finishing the mechanism of injury of the meniscal tear, let's find out which meniscus are more prone for the tears. The medial meniscus are more prone for the tears. Now, why is it so? The medial meniscus, in our previous lecture, we said that it was related to an important structure. What was that structure? Yes, that structure was the tibial collateral ligament. The tibial collateral ligament deep part is attached to the margins of the medial meniscus. Because of this attachment of tibial collateral ligament deeper part to the margins of the medial meniscus is relatively fixed on the tibia. And the lateral meniscus, if we look into the lateral meniscus and look into the relation of its relation with the fibular collateral ligament or the lateral collateral ligament, it is free from the lateral collateral ligament. There is no attachment to the lateral collateral ligament. Addition to that, the muscle which is related to the posterolateral aspect of the lateral meniscus that we discussed in the previous lecture was the very important relation, was the popliteus muscle relation. So this popliteal muscle, which is related to the posterolateral aspect of the lateral meniscus, this is going to pull the lateral meniscus into more favorable positions whenever there is a sudden movement. So the lateral meniscus is relatively free to move on the tibia during sudden movements. But the medial meniscus, being more fixed, it will be teared. Now, after meniscal tear, we begin with the ligament injury. The first ligament injury which we'll talk about is the medial collateral ligament injury. Before doing so, let's revise the anatomy of medial collateral ligament. It was the ligament which was strengthening the knee joint from the medial aspect. It was arising above from the medial condyle of the femur, and then below it split into two layers, a deeper layer which was attached to the articular margin of the tibial condyle, and the superficial layer was attached to the upper part of the shaft on the medial surface. Now, what is the mechanism of injury leading to medial collateral ligament? This red arrow shows the direction of force or blow. So the blow to the outer aspect of the knee joint, which is a valgus stress, this leads to the forceful abduction of tibia on the femur, leading to tear or injury in the medial collateral ligament. The other collateral ligament, which is on the lateral side, is the lateral collateral ligament. It was arising from the lateral epicondyle above of the femur, and below it is attached to the head of the fibula. So this ligament is less commonly injured as compared to the medial collateral ligament. The mechanism of injury is the varus stress, which is the force on the inner aspect of the knee joint. This is going to stretch the lateral collateral ligament because there will be forceful adduction of tibia on the femur. Now we come to the most commonly injured, most frequently injured ligament in the body, and that is the anterior cruciate ligament injury. Now in this picture, you can see the anterior cruciate ligament. The anterior cruciate ligament, remember, it was arising from the anterior part of the intercondylar area from the tibia, and it was inserted to the medial surface of the lateral condyle, posterior part of the lateral condyle, its medial surface. Now, do you remember the functions of the anterior cruciate ligament? Yes, it was the prevention of the posterior displacement of femur on tibia, and with the knee flexed, it was preventing the tibia from being pulled anteriorly. So, by keeping these functions in mind, now let's see what is the mechanism of injury for the anterior cruciate ligament, which is the most common ligament injured in our body, and among the posterior and the anterior, this is the commoner. So the first picture shows a footballer, and you can see that his left knee joint is affected. Now let us see the pathophysiology of this anterior cruciate ligament injury. Now, this deceased individual is pivoting. That means he is suddenly balancing his weight. He's suddenly balancing his posture. So why so? Because there is a sudden deceleration with a change in direction. So whenever there is pivoting, that is sudden balancing of the body, because of the sudden deceleration with a change in direction, the foot obviously is stuck in place. With while it is on the rest, but the torso, the upper part, is continuing its rotatory movements. So this is going to result into a valgus stress with possible external rotation of tibia. So the tibia is going to externally rotate, and the knee in this condition is flexed. So once a patient with anterior cruciate ligament injury comes to a clinician, how a clinician is going to assess whether he has anterior cruciate ligament injury or not? For that, we do the anterior draw test. For this test, we should know the function of anterior cruciate ligament. The function of cruciate ligament was prevention of posterior displacement of femur on the tibia, applying of the function of anterior cruciate ligament. What is done is the clinician tells the deceased individual to lie on his back, and he's asked to flex his knee by 90 degrees. The knee is flexed by 90 degrees. And so by doing this, the femur has been stabilized, and the clinician then holds the knee joint, and with his thumb is going to apply pressure onto the proximal tibia, and is slowly going to draw the tibia anterior. So the proximal part of the tibia is drawn anteriorly by the clinician. So if the anterior cruciate ligament is intact, what is the function of anterior cruciate ligament? With the knee flexed, the anterior cruciate ligament was, yes, it was preventing the anterior displacement of tibia on the femur. But if anterior cruciate ligament is torn, or there is an injury to the anterior cruciate ligament, the tibia will be drawn anteriorly, and so that soft endpoint will be there. So it will be easily drawn anterior. The tibia will be easily drawn anterior. So this is a positive anterior draw test, which is confirmatory that there is anterior cruciate ligament injury. So now coming to the posterior cruciate ligament injury. They are less common as compared to the anterior cruciate injury. So the posterior cruciate ligament, remember, it was rising from the posterior most part of the intercondylar area, and it inserts to the medial condyle of the femur onto its anterior part along its lateral surface. The function of posterior cruciate ligament is to prevent the anterior displacement of the femur on tibia. So it has the opposite function. Prevention of anterior displacement of femur on tibia, and with the knee flexed, it is going to prevent the tibia from being pulled posteriorly. So the posterior displacement of the tibia will be prevented. Now, the mechanism of injury is usually the hyperextension injury. The hyperextension injury, so you can see this footballer with the hyperextended knee. This is the mechanism of injury. With the flexed knee also, the posterior cruciate ligament can be injured, and with the flexion of knee when there is associated plantar flexion. For example, the dashboard injuries. Now, the confirmatory test for the posterior cruciate ligament injury is the posterior drawer test. In the posterior drawer test, again, the patient lies on his back and the knee is flexed to the 90 degrees, similar as in the anterior drawer test. But here, the force which is applied on the proximal part of the tibia is in the posterior direction. So the proximal end of the tibia is pushed posteriorly. So we know that the function of posterior cruciate ligament with flexed knee was prevention of displacement of tibia in the posterior direction. So if this posterior drawer test is done with an intact posterior cruciate ligament, the intact posterior cruciate ligament will prevent the posterior displacement of the tibia. But here in the posterior cruciate ligament injury, the tibia will be drawn posteriorly, which again is confirming the posterior cruciate ligament injury. Now coming to the diagnostic and therapeutic modality involved with the knee joint is a process which is called as the knee arthroscopy, where a small incision is made on the knee and through a camera, which is an arthroscope. This arthroscope is inserted into the knee joint, and all the internal structures like ligaments, menisci are directly visualized on the screen. And this can be done both for diagnosing as well as for treating the patient. Now, the next pathology is very common pathology, and it is involving mostly the elderly individuals. So in this osteoarthritis, there is degeneration of the knees articular cartilages, and they may involve the underlying bone as well. Most commonly for that osteoarthritis, in untreatable osteoarthritis, the last resort is the knee arthroplasty, which is the surgical procedure in which the weight-bearing surfaces of the knee joint, which have already been eroded because of the osteoarthritis and causing pain and disability. So those weight-bearing surfaces are replaced with the metallic prosthesis. So this is called as the knee arthroplasty. Now coming to the movements of the knee joint. The movements on the knee joint are flexion, extension. Along with the flexion extension, there are conjunct rotations, that is medial rotation, which is the internal rotation, and the lateral rotation, that is the external rotation. The extent of flexion and extension is the flexion can be done 120 degrees up to 120 degrees with hip extended and up to 140 degrees with flexed hip. The extension can go 5 to 10 degrees beyond the vertical femorotibial axis. The conjunct rotations are approximately 20 degrees. The flexion and extension that is happening at the knee joint are little different from the hinging movement of flexion and extension at the elbow joint. So how it is different from a true hinging movement? The axis of movement is not fixed. The axis of flexion and extension is not fixed. Why? Because the femoral condyle have a spiral profile, which we discussed previously in the last lecture. So because of the spiral profile of the femoral condyle, during extension, the axis of flexion and extension is shifting upwards and forwards. And during flexion, the axis of movement goes backwards and downwards. Also, the flexion and extension are not pure movements. They are associated with conjunct rotation. So along with the flexion, there will be some rotatory movements. Along with the extension, there will be some rotatory movements taking place, which is unlike a hinging movement. And this conjunct rotation, why there are associated conjunct rotation along with flexion and extension in the knee joint? Because of its complexity. The knee joint was very complex. Its articular surfaces are complex. The muscle surrounding it is acting and pulling it, and the ligaments surrounding it. So these all contribute to the conjunct rotations at the knee joint. So now let's learn the mechanism of flexion and extension. So we'll start with the extension. Extension from a full flexed position. So a full flexed position when the foot is on the ground. For example, right now, if you are sitting on a chair, the foot, your knee joint is flexed. Now, fully flex your knee joint. Now, when you have fully flexed your knee joint, now start standing up. When you are standing, what is happening? You are going from a full flexed position to the full extended position of the knee joint while your foot is still on the ground. So we are now discussing the mechanism when there is extension from the full flexed position of the knee with foot on the ground. Right? So can you see this picture over here? This picture, the first picture is the picture of fully flexed knee joint. A full flexed knee joint, we have already discussed that in a full flexed knee joint, what is happening? This is the femoral condyle, and the lower one is the tibial condyle, and this is the anterior part of this picture, that is the tibial tuberosity. So in the full flexed position, what happens is the contact point is the posterior parts of the tibial articular surface and the menisci are in contact with the posterior femoral articular surface. It is more curved. The anterior ones were more flatter. So what is in contact with the tibial are making a contact point with the tibia and menisci in the condyles each other. So is it a congruent state of articular surfaces? No, it is the maximally incongruent state. So in this position, there is minimal contact between the articular surface, making the full flexed position as a maximally incongruent position in the knee joint. So now, while you are sitting, you were in the flexed position. And when you fully flexed your knee joint from that position, from the full flexed knee joint position, when you begin to extend your knee joint, that is the early stages of extension. So what happens in the early stages of extension from the full flexed position? In the early extension, the femoral condyles roll forward. So the rolling movement is taking place in a forward direction. Simultaneously, the femoral condyles slide backwards on the tibia. This is to maintain the contact. Now, because of this rolling and sliding movement, the knee joint is undergoing extension. So in the picture, we can see earlier the point number 3, in the earlier picture, the point number 3 was making a contact with point number 2 on the tibial part. But later, what happened is the more anterior portions of the femoral condyle, that is number 2, is making contact with the number 2 area on the tibia, T2. So when the knee joint is beginning to extend, now when the extension is taking place at both lateral femoral condyle and medial femoral condyle. But do you remember which femoral condyle was longer in anterior posterior plane? Yes, it was the medial femoral condyle, and the shorter femoral condyle was the lateral femoral condyle. So which femoral condyle will reach its full congruency earlier? Yes, it will be the lateral femoral condyle. So what happens is when the extension is taking place, the lateral femoral condyle being smaller will reach its full congruency. That means its full articular surface will be utilized earlier as compared to the medial femoral condyle. And this happens just 30 degrees before the full extension of the knee joint. So that means to complete the extension process, we must have another mechanism which is called as the locking mechanism. So what happens in locking is the lateral femoral condyle articular surface is already used up. Now we are left with the medial femoral condyle, whose articular surface is still not utilized fully with the extension. So in this locking mechanism, what happens is, which is happening just 30 degrees before the full extension. So what happens in the last 30 degrees of extension, locking mechanism takes place. So when the foot is on the ground, what happens is to complete the full extension, conjunct medial rotation takes place of the femur on tibia. So in this picture, you can see the femur is undergoing medial rotation. This medial rotation of the femur is taking on the tibia, and the axis of this medial rotation is a vertical axis, and this vertical axis passes from the head of the femur to the lateral condyle of the femur. So because of this conjunct medial rotation, now what will happen? This is now then going to bring the anterior horn of lateral meniscus. This is the anterior horn of lateral meniscus. This anterior horn of lateral meniscus will be brought to the anterior slope of the tibia. Why? Because the femur has medially rotated. So when the femur has medially rotated, the lateral condyle will also get rotated, right? So leading to the anterior horn of lateral meniscus to the bringing this anterior horn of lateral meniscus to the anterior slope. So now what will happen? The full congruency of lateral condyle is, because of this, the full congruency of lateral condyle is delayed. So we have delayed the process of full congruency of the lateral condyle, and extension can now continue. So this leads to so finally the full extension can take place after the locking mechanism. So the locking mechanism is taking place in the last 30 degrees of extension and involves the medial rotation of the femur on tibia. So now let's revise the extension process from a full flexed position. So in a full flexed position, the posterior portions of the femoral condyles are making contact with the tibia. When we begin extension from the full flexed position, what happens is this femur rolls forward. So there is rolling forward movement of the femur and simultaneously sliding backward movement of the femur. Now, since lateral femoral condyle is shorter, the lateral femoral condyle will approach its full congruency about 30 degrees before the full extension process than the medial condyle. And because of that, the simple extension process cannot continue. Therefore, there will be locking mechanism in which there is medial rotation of the femur, which occurs on a vertical axis. And this vertical axis passes through the head of the femur to the lateral condyle of the femur. Because of this medial rotation, conjunct medial rotation of the femur on the tibia, the medial femoral condyle is turned backwards. And the resultant rotation of the lateral condyle, associated rotation of the lateral condyle of the femur, will bring the anterior horn of lateral meniscus to the anterior slope of tibia. So the contact surface for the lateral femoral condyle is increased. So the process of full congruency of lateral femoral condyle is delayed. So after that, full extension process can continue, and this full extension process is called as, after full extension is called as the locked position. So after finishing the process of extension from a full flexed position, now let's see what happens when there is flexion from the full extended position. So when you are standing, for example, you are standing. When a person is standing, it means the knee joint are in which position? They are in the position of locked position, that is the closed back position. So if the knee joint are locked in that condition. So when a person is standing, now start flexing the knee joint from the standing posture. That is flexion from the full extension position. That means flexion from the locked position. So that process should reverse the process of locking. So that is called as the unlocking process. So the unlocking is the process of beginning of the flexion from the full extended position. So what happens is, before we begin the flexion from the extended position, the joint, the knee joint, which is in a locked position, must be unlocked first. And how this unlocking takes place? By reversing the conjunct rotation of extension. So remember, when the extension, last stage of extension is taking place, the last 30 degrees of extension were taking place, when the foot was on the ground, what was happening? The locking was happening. And in the locking, what happened was, there was medial rotation of the femoral condyles. Medial rotation of the femoral condyle took place on the tibia. So after that, the knee joint came into a full locked position. So if we want to flex the joint from full extension position or full locked position, we must unlock the joint. And the unlocking will take place by reversal of movement. So now unlocking will take place by reverse movement. That means there will be a conjunct lateral rotation. So the lateral rotation of the femur on the tibia will take place. And this is brought about by the popliteus. And when the foot is on the ground, the lateral rotation of femur is taking place. But if the foot is off the ground, there will be a medial rotation of tibia on the fixed femur. So after this unlocking, now the joint has been unlocked. Now the flexion can commence. So how will the flexion take place? The flexion will take place by rolling backwards and sliding forwards of the femur. And by that, rolling forward and sliding, rolling backward and the sliding forward, we now reach to the full flexed position. The locked position is the position of maximum congruency and compression at knee joint. The capsule and all the ligaments are maximally taut, making the knee as a solid pillar. Skin and fascia is also taut. Whereas in the flexed position, only the fibular collateral ligament and the posterior portion of tibial collateral ligaments are relaxed. Rest all, the anterior cruciate ligament, posterior cruciate ligament, and the anterior portion of the tibial collateral ligament are taut. So at the end, the muscles which are causing the movements are, for the extension, the quadriceps femoris, biceps, semitendinosus, semimembranosus brings the flexion, Medial rotation is brought about by popliteal semitendinosus, semimembranosus, and biceps is involved in the lateral rotation. So at the end of the lecture, the take-home messages are medial meniscal tears are more common than the lateral meniscus. Anterior cruciate ligament are the most commonly injured ligament of body. Flexion, extension, conjunct, medial rotation, and lateral rotation are the movements that take place at the knee joint. Locking is the terminal stage of extension, which involves conjunct lateral rotation of tibia on femur when foot is off the ground. Unlocking is the early stage of flexion from the full extended position, and it involves the opposite movements of the locking mechanism. Thank you, students.
भेजा है मसाला पकाने के लिए, पका दिया उन्होंने। हाँ आज कैसे चला, शुरू में कोई दिक्कत आई थी? ओके अच्छा एक चीज है, आपने अभी बैठी 2 मिनट बैठ सकते कि आपका अटेंड बैठ सकते हैं आप? नहीं आज बैठ नहीं वैसे भी कोरोना के चक्कर में धीरे धीरे बैठना सीख गया। हाँ मैं पूछा था कि आपके लेक्चर अटेंड करने के बाद आपको क्या कहना चाहते हैं? हाँ आज देखी तो हुआ। अच्छा आपका तो नहीं, अच्छा सुबह का हाँ उनका भी बता देंगे।
ऐसे तो सारा अच्छा तक पर कहीं बीच में आवाज ब्रेक होती है।
चलो कोई बहुत तो नॉर्मल है, वो तो हमारे लेक्चर में भी तो जाती है।
बाकी तो तुम अच्छे से कर रहे हो, कोई प्रॉब्लम नहीं है। लेकिन ये पॉइंट तो ज्यादा अच्छे से दिखता रहता है, अगर ये रिकॉर्ड हो जाता है तो बाद में क्लियर करने में आसान रहता है ना।
नहीं बुरा क्या लगा? बुरा हाँ तो अच्छा बुरा दोनों चाहिए।
बुरा तो ऐसे कुछ नहीं लगा।
चाय देंगे?
क्यों बैठे?
बस ये खत्म कर मैं आगे निकल रहा हूँ। नहीं इसमें पता है क्या हो गया, मैं विजयपाल बन गया हूँ। मैं विजयपाल बन गया हूँ।
तो मैं तुमको बोल रही थी ना कि सबको सिखा दो, सब करे अपना, पर इसमें क्या है? अगर वो आईडी जो भी है वो सबको तुम प्रोवाइड करना, जो लेक्चर ले रहा है
तो इसमें ये
परेशान लगाओ, तुम्हारा टाइम तो पूरा जाएगा, लेक्चर कोई और लेगा उसका तो
डबल ट्रिपल टाइम लग रहा है।
डबल ट्रिपल तुम्हारा तो कंटीन्यूअस टाइम जा रहा है, हम तो जैसे एक चीज करके बैठे हैं, तुम तो उसे में लगे हो।
एक वो तो एक इशू है ही है, that everybody should do it on their own, इसमें कोई बड़ी बात है नहीं।
मैंने सुबह से थोड़ा सा सीखा भी, तो कुछ भी मुश्किल नहीं है, कभी मुश्किल होगा तो पूछेंगे तो
कोशिश तो करे, कोई कोशिश नहीं करे
मैं यार कोशिश कर,
तो कौन कोशिश करेगा? अगला किसका है? अगला किसका है?